One blood clot can stop your heart from pumping effectively in a matter of minutes. A patient suddenly becomes short of breath. Their heart rate jumps to 130. Their oxygen level is falling. They complain of sharp chest pain every time they take a breath. If you don't recognize what's happening quickly, the outcome can be fatal. This is pulmonary embolism. Today, instead of memorizing a long list of tests and treatments, I want you to answer one simple question. What is pulmonary embolism doing to the body? Once you understand that, nearly every symptom, diagnostic test, and treatment becomes logical instead of something you have to memorize. Let's walk through it together. Normally, blood leaves the right side of the heart and travels to the lungs, where it picks up oxygen before returning to the rest of the body. In pulmonary embolism, a blood clot suddenly blocks one or more pulmonary arteries. Blood can no longer reach portions of the lung, so oxygen exchange begins to fail. That's why patients develop sudden shortness of breath, rapid breathing, hypoxia, and often sharp chest pain that's worse with inspiration. Since oxygenation is your first priority, begin immediate stabilization. Give supplemental oxygen, place the patient on continuous pulse oximetry and cardiac monitoring, establish intravenous access, obtain frequent vital signs, and transfer unstable or deteriorating patients to the intensive care unit. While you're stabilizing the patient, perform a focused cardiopulmonary examination and don't forget the legs. Unilateral leg swelling may point to a deep vein thrombosis, which is the source of most pulmonary emboli. But pulmonary embolism isn't just a lung problem, it's also a heart problem. Think about what happens when blood suddenly can't move through the lungs. The right ventricle has to pump against a blocked pulmonary circulation. As the pressure rises, the right ventricle begins to struggle. If enough of the pulmonary circulation is blocked, the heart eventually can't keep up, leading to hypertension, obstructive shock, and potentially cardiac arrest. Now the patient's tachycardia and instability suddenly make sense. To determine how much strain the heart is under, obtain an electrocardiogram, troponin, and brain natriuretic peptide, or BNP. An echocardiogram can also evaluate right ventricular function, especially in unstable or high-risk patients. These tests don't diagnose pulmonary embolism, but they tell you how severely the heart is being affected, and that helps determine how aggressive your treatment needs to be. Now we know why the patient is hypoxic. We know why the heart is struggling. The next step is finding the clot. The best test in most patients is CT pulmonary angiography with intravenous contrast because it directly visualizes the embolus inside the pulmonary arteries. If intravenous contrast can't be used because of severe kidney disease or a contrast allergy, obtain a ventilation perfusion or VQ scan instead. Since most pulmonary emboli begin as deep vein thromboses, order a Doppler ultrasound of the lower extremities to identify the source. At the same time, complete the remainder of your workup. Obtain a chest X-ray to evaluate for other causes of chest pain or shortness of breath, and send routine laboratory studies including a complete blood count, comprehensive metabolic panel, coagulation studies, and arterial blood gas when appropriate. One important board pearl involves the D-dimer. D-dimer is useful only when pulmonary embolism is considered unlikely or moderately likely. If your suspicion is already high, skip the D-dimer and move directly to definitive imaging. Once pulmonary embolism is confirmed, or your suspicion is high enough that treatment shouldn't wait, the goal becomes simple. Stop the clot from causing more damage. For hemodynamically stable patients, begin anticoagulation with medications such as apixaban, rivaroxaban, low molecular weight heparin, or intravenous heparin with transition to warfarin when appropriate. If the patient is hypertensive or in obstructive shock from a massive pulmonary embolism, immediate reperfusion is required. That usually means systemic thrombolysis with alteplase. In selected patients, catheter-directed thrombectomy or surgical embolectomy may also be necessary. Continue reassessing oxygenation, blood pressure, and right ventricular function throughout treatment. Patients who worsen require intensive care, while stable patients can eventually transition to long-term anticoagulation with close outpatient follow-up. Before we finish, here are a few common CCS mistakes that are easy to avoid. Don't forget the electrocardiogram, troponin, or lower extremity Doppler ultrasound. Don't order a D-dimer when pulmonary embolism is already highly suspected. Don't delay anticoagulation after the diagnosis has been established. And never discharge a patient without a clear long-term anticoagulation plan. So let's come back to the question we started with. What is pulmonary embolism doing to the body? It's blocking blood flow through the lungs, preventing normal oxygen exchange, and placing dangerous pressure on the right side of the heart. Once you understand those three problems, everything else follows naturally. Oxygen treats the hypoxia. ECG, troponin, BNP, and echocardiography assess right heart strain. CT pulmonary angiography finds the clot. Lower extremity Doppler ultrasound identifies where it came from. and anticoagulation prevents the clot from getting larger while the body gradually breaks it down. If you remember one thing from today's episode, remember this. When a patient develops sudden shortness of breath, hypoxia, tachycardia, and pleuritic chest pain, think pulmonary embolism until proven otherwise. Find the clot, protect the right heart, and start anticoagulation without delay. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.